You're listening to the Pelham Podcast with Tony Kay, the show that highlights all things Pelham Medical Center. Thank you for listening. For more information, visit pelhammedicalcenter.com.
Well, welcome everybody to another edition of the Pelham Podcast. Joined today by two ladies from Spartanburg Regional Healthcare System's Post-Acute Division. Post-acute care services are, in general, things outside of the acute care hospital. So if you have somebody go to a rehab facility or a nursing home, home care, those are services that in healthcare parlance are called post-acute. And Leanne Thompson is the system director within our post-acute care services and has responsibility for case management. And Carla Lamb's the chief nursing officer of our post-acute care division. Ladies, welcome.
Hey, thanks for having us.
Well, very glad y'all are here. I think, these stories or discussion topics can really hopefully helpful for the audience, because I think people naturally assume most healthcare is a doctor's office or a hospital, and there's so much to the industry that might not be known until you need it. So this will be, I think, a very informative discussion. But Leanne, why don't you tell our audience a little bit about yourself, your background, and how you got to the role you're in now?
Absolutely. So this past year, I celebrated my 28th year with the system. So my entire adult life, I have worked in case management through Spartanburg Regional Healthcare System. I started off as a floor orthopedic case manager, spent about 5 years at the Church Street campus, and then I transitioned over to post-acute, where I spent about 20 years. And recently, I guess the last year and a half, I took the role of the system director of case management for the system. All right. So that includes all campuses, including post-acute.
And you grew up in Spartanburg?
I did not. I actually grew up in Cherokee County. Social work was not. I was probably your non-traditional student, or maybe it's more traditional. I had no clue what I wanted to do as an 18-year-old at the College of Charleston. And then so I bounced around a couple ideas, and I did an internship, a social work internship at Spartanburg Regional 29 years ago. Wow. And I've really never left since. I think it was a natural fit for me being a social worker. As my mother would always say, I was really nosy. So I love hearing people's stories. How can you help somebody? So it was a great fit for me.
Cool, great. Well, and I think that, case management's another function, while it's in the acute care hospital, is probably something that most people don't think about either. So we'll get to dive into that
absolutely
a little bit. Carla, what about you? Give us a little bit of your history in the upstate and with Spartanburg Regional.
So I am from Spartanburg County. I grew up in this area. I originally started my career nursing by trade, graduated from USC upstate. It was Spartanburg then, USC Spartanburg. Graduated from there, began my nursing career at Mary Black Hospital, actually, and learned a lot about nursing. I had a role as a nurse manager, charge nurse. That's the flexibility in nursing, just done all kinds of things. And then joined a team that was brand new at the time, was case management. And so that's where I originally got my training. Leanne and I met about 20 years ago. She convinced me to come to Spartanburg Hospital for restorative care over to the post-acute space. And so I did that. Really enjoyed learning a lot about our healthcare system, working with the various campuses, working in post-acute, learning that industry. And then the opportunity came available in 2019, and I accepted the chief nursing officer role for the post-acute division, which is really exciting. So my career started in nursing, dipped into case management, back to clinical nursing, where I get to use both sides of my hat now. So I'm enjoying that.
That's great. And y'all have worked together a long time, so you've got some dirt on each other. We won't explore that
Absolutely.
in today's session. But
that'd be good. That's for a later session for
sure. Well, and
Tony.
we've definitely got some experts here that I think our audience will ultimately value y'all's perspective on how your part of the healthcare system and industry works. So, why don't you one of y'all take a stab at maybe defining what post-acute care services is? How is it different than what people might think of a traditional hospital? Because there's really a lot to it.
Yes. You want me? I'll take that one. So for post-acute services for our healthcare system, we have a long-term acute care hospital. That's Spartanburg Hospital for Restorative Care. We have 3 skilled nursing facilities. One is a short-term skilled. It's in Spartanburg Hospital for restorative care. And we have 2 residentials, which would be Ellen Sager and Woodruff Manor. And they can also accept skilled residents. We have home health services, which serves 4 counties for the upstate. We have hospice, which does the same. And we have a hospice house. And we have an acute rehab. And post-acute services, best described, I think, is that we are the partner with the acute care hospitals to be able to help people get back to their best life, help them meet their goals, whether it return home or if they need some short-term rehab before they go home. We want to come alongside them and do that. In our system's post-acute division, we have the benefit of really being able to work with the healthcare system. We have the same physician practices, the medical group of the Carolinas, so we have the same healthcare records, and that makes it really nice for us to come alongside our healthcare system and physician practices to serve our community in that way.
And explain for the audience a little bit about, you used the word skilled nursing, versus other kinds of services within post-acute. Explain to everybody what that means.
So skilled services, so if we're talking about skilled nursing facility, sometimes folks need to go into a skilled nursing facility for the focus of just skilled rehab, and then they may not be able to go home and they're going to become residential at that point. We have 2 skilled facilities that we can do that in. And home health, skilled by the term for home health is really, we need that nurse or physical therapist to come out and come alongside those patients to make sure that they have every opportunity to return to optimal health, and they require the skill of a registered nurse or a therapist or a CNA to come alongside to help them retrain, regain, that kind of thing. Skilled, we use skilled terms in post-acute all over, about like the acute care hospital uses the word inpatient and observation. And so for post-acute, we want to make sure that we have folks that have a skilled need. And so that's, I probably use
like
that.
a nurse or a therapist.
Yes, like a nurse or a therapist, yes.
Okay. Yeah, and I think, so you've got what we call the acute care hospital, which is if you go to the hospital, that's what people normally would traditionally think of. And by acute, we're trying to treat a current situation and take care of people and then get them either home or to the next level. So you brought up acute rehab. Talk a little bit about what you might do in there. Obviously, people are getting rehab services, but what do you do in an acute care or acute rehab facility?
We use the term, you'll hear rehab used a lot, that covers several different spaces. As you talked about, the skilled level of care is rehab, but we also have an acute rehab. And for those patients that need a little more intensive therapy, so for an acute rehab, under the guidelines, you have certain diagnoses, but you also need to be able to tolerate 3 hours worth of therapy a day. So you work with your case manager and your physician, and therapy is a huge part of the care team that helps you decide which is the most appropriate level of rehab that you need. But an acute rehab is really set up, and they do a phenomenal job if you've had a stroke or an amputation or a hip fracture, and you can tolerate that therapy and need the physician intervention.
Okay. And you also mentioned the word long-term acute care hospital, or LTAC, and that's another component of our industry. And maybe tell everybody a little bit about what an LTAC does.
So a long-term acute care hospital really takes the sickest of the sick patient. From the acute care hospital, we receive about 70% of all of our admissions from a critical care unit, or what the acute care hospitals call an intermediate or step-down unit. Those patients are very complex. Our average length of stay is about 25 days. And they require, usually we accept patients who are acute respiratory failure or who are on the ventilator, requiring long-term IV antibiotics, really complex wounds. That's our favorite type of patient. That industry, the long-term acute care hospital, has been able to show really evidence-based how that industry is valuable. So we accept those from all over.
Okay. Yeah, and that really sort of is helpful because what we're trying to do here is inform people. And so for the listening audience, what y'all have heard is, we've got different components of service locations within the healthcare industry. Spartanburg Regional Healthcare System has these resources because if we didn't, our acute care hospitals would just stay jam-packed full with people who, in many cases, didn't need to be there. And the healthcare industry has created these other entities that are, what I guess, for lack of a better term, more capable or better capable of taking care for those specific needs to free up the acute care hospital, which is designed for short stay and shorter stay patients, and people can get care that they need in different locations. And so I think that's hopefully for you guys listening very helpful in understanding why healthcare is set up this way. Every one of these different locations has a different cost structure to it, as well as the resource requirements, and that's really why it's set up the way it is. So I think that's very helpful. Thank y'all. At a high level, we've talked through a little bit about just the various components of the healthcare industry, and by and large, I think it's fair for our audience to know that Medicare drives a number of things, and some of these services get created because the government is looking for ways to find lower cost locations for services. I'm not saying that quality isn't imperative in the government's mind, and in fact, oftentimes these people do get better care because that's what their focus is at these locations. But the chief driver oftentimes has been, payment schema so that, we can get people out of the hospital. So understanding that, talk to us a little bit, because I think people use the word putting mom or dad in an assisted living. Leanne, talk to us a little bit about what assisted living is, and is that something that would be traditionally covered by insurance?
Absolutely, I'd be glad to. So assisted living is basically like it says, that it's a place that you can go to stay and live where you get a little bit of assistance. They can help with meals or bathing or medications. It's a great place where mom or dad or yourself's not doing well at home and you need some help, but you're able to do some things. And assisted living is a great option because you have that 24-hour support at that facility. However, one of the barriers that we see for assisted living is payment. Unfortunately, insurance companies of any sort, Medicare, Medicare Advantage, private, do not cover assisted living. So it is the responsibility of the patient and family.
Okay. And that's helpful because that word, gets said a lot, and I don't know that everybody fully understands that comes out of someone's pocket directly.
No, there are let me give on the assisted livings. If you go to an assisted living and you need additional support that they allow, like home health services, hospice services, outpatient therapy that they may have in their facility. Now, that is covered under your insurance. It's just basically the room and the board of the assisted living. Yeah. So if you need specialty services, your insurance traditionally covers those. So it works in conjunction with that.
But if you put somebody in a skilled nursing facility, that's generally going to be an insurance-driven.
It is, as long as you have the skilled need, absolutely.
Okay. All right. So, and do understand that, because that's pretty critical, the way these things are set up. Both of y'all have a background in case management, so it might be helpful as we start to sort of unfold what post-acute care does and how it's important within our system, maybe telling everybody a little bit about what case management does, and then what are some of the requirements about getting somebody from a hospital to a nursing home or an acute rehab or an LTAC? What are some of the things that y'all experience in trying to get people from a hospital to the next place of care?
I'll give Pelham as an example. So case management here, our case managers are located on each floor in each area. So on admission, based off referral, when I say referral, we use that term extremely loosely. Anybody can make a consult or referral to case management. The therapist, the physician, families can always request a case manager to see them. And our biggest function here at Pelham and other acute care hospitals is really helping patients and families transition to what's next when they leave here. Majority of our patients go home and need nothing from us, have no service needs. But we see a lot of folks that need something once they leave here. So the case manager does an assessment with the patient and family, and they work together with their care team, physician, nurses, therapists, to determine what their location, what their post-acute need is going to be when they leave here. And based on kind of where they are, what their needs are, then they go from there. Let's give the example of skilled nursing facility. It's determined that your loved one's going to need to go to a short-term nursing home for rehab once they leave here. What does that look like? It varies sometimes on your payer. Let's say, for example, if you're a traditional Medicare patient, you have to have something called a 3-night qualifying stay, and that has to be an inpatient stay. So I know that's something we work with a good bit. We have to have conversations, sometimes harder conversations with families, because there's different types of statuses when you come in based on your medical need. If you come in and you're in an observation status, which means, you're here to be here for us to observe you, but you don't meet the criteria to be inpatient. We're expecting your medical needs to be met in less than 2 midnights. Then Medicare does not recognize that as a qualifying stay. Now, if you come in and you're inpatient after that 3rd night, you qualify for Medicare coverage as long as you have the skilled need. We do have some examples of a Medicare Advantages that don't always follow that same rule of Medicare and do allow folks to go at some point in observation to skilled nursing facilities. Same thing with inpatient rehab. If it's determined that the best location for them, we go over choice of agency, we make the referrals, and we work with their payer to see, okay, yes, this is the right level of care. And then the case manager works with that facility to get them their pre-cert started and completed before they leave.
Very good. And I think you hit on something that, the hospital in particular has got, so many different groups that ultimately serve the patient in some way. And I think, hopefully what Leanne just mentioned gives you a bit of a flavor of the value of case management. I mean, we've got a lot of experts in a lot of different areas, and case managers are really critical in getting people the resources they need to get better once they're done with the hospital. Some people might, feel like the hospital's trying to get you out of the hospital, but really what they're trying to do is make sure that you've got all that you need to have the best life once you don't need to be at the hospital anymore. And they really play an incredibly valuable role in that they're really one of the many advocates, but a big advocate for the patient in getting them somewhere. And they do experience some challenges in finding placement opportunities, whether they're full or some places won't take a patient. But hopefully for you guys listening here, you get a real flavor that when you meet a case manager and they talk to you about all this stuff, you understand the key role they play in helping you or your loved one. And if in a situation where you don't feel like you can take care of mom or dad, that's a factor that gets taken into account that the work that they do.
Absolutely. And they work really as the liaison, right? Dead in the center of it between everybody. I mean, with your physician, with the post-acute agencies, those type of thing. They're there to help you navigate these waters that are, personally, it's newer for us dealing with elderly parents. Man, it's harder than raising children.
Yeah.
So it's, they're there to help.
Yeah, absolutely. Absolutely. I think that, Carla, you mentioned just sort of in a broad review of what post-acute care was. You talked about hospice care. And, another thing that people might not quite understand is a term called palliative care. And why don't you talk a little bit about what palliative care is and how it's different from hospice care? Because I think that creates some confusion. Our job here at the hospital is try to take the best care, evidence-based that we can. We want people to be comfortable. There are times that nothing else can be done.
I'll be glad to. So palliative care really has been helpful across the system in coming alongside folks and helping establish goals of care. A lot of times when our patients are admitted to the hospital or they get a list of diagnoses that they are just unfamiliar with, palliative care can come alongside a patient, family, loved one, and help walk through prognosis and what their goals of care are. Sometimes folks say, my goal is to not be on so many medications, and I understand that you cannot cure my heart failure. I want to feel better. I want to wake up and take less medications. Palliative care can come alongside and work with the physician team in both the acute care or medical group of the Carolinas to make sure that they understand the patient's goals of care and that their medications are maximized. They also do a great job of coming alongside families and helping explain prognosis. And sometimes after palliative care has worked with folks who are not able to be cured, there's a chronic condition that they know that they cannot reverse, because we love to reverse conditions in healthcare. We love to cure. Sometimes hospice is a good route, and sometimes that's a stepping from palliative. And hospice does a really good job of walking alongside a patient who has a diagnosis of potentially prognosis 6 months or less. Sometimes that's longer. We have seen folks live longer. We don't have crystal balls, definitely, in healthcare to know lifespan, but we know that we have a condition that's not going to turn around. And hospice goal is to maximize the days that they have. It's certainly not to shorten life. Sometimes people get that very confused. Our goal in hospice is to help those patients live the fullest that they can in the days that they have left in the most comfortable medication management possible. That's our goal in hospice, and it's one of my favorites in post-acute, but certainly we have a great hospice program at Spartanburg Regional Healthcare System.
Absolutely. Yeah, that's a great explanation, because I think most people think we're going to call in hospice or we're going to execute palliative care, and people think that means it's a death sentence. And while you mentioned that we're dealing with something that might not be curable, that does not mean that someone can't continue to live as good a life as possible. It's just much better than just sitting in the hospital forever for something that can't be cured. And so, hope is that you guys listening get a little bit of an understanding that when those services are called in, it's really to make the loved one be as comfortable and as fruitful in the time they have left. And like Carla said, there are people who sometimes spend over a year in hospice care because they just are still living, but they really don't have something that needs to be treated in a hospital. So I think that's a great explanation for that. We also, you talked a little bit about home health, just in the broad overview. Talk to us about what kind of services are done in the home and how all that works as well.
So home health, we have one of the oldest home healths in the upstate. And it's interesting because home health has evolved over time. And one of the things that I enjoy most about home health, and I think is probably little known about home health, is that in home health, you have the ability to have a registered nurse or physical therapist or occupational therapist come into your home, evaluate the home situation, marry that, collaborate with your physician who sent the referral, and then be able to share what we see in the home and how we can help make sure the patients understand their medications, make sure that their home environment is safe. We may see a rug that we've seen the patient has been readmitted twice because they've gone home and tripped or fallen, and then we'll send in a skilled therapist and they'll be like, hey, have you thought about maybe let's take this rug up? And folks don't think about those little things because in the acute care hospitals, or really any place in healthcare, medical group of care, they can't see into the home. So home health is really the partner to say, let's get every medication you take out of the cabinet. Let's look at them. Make sure we've got a full list, reconcile those back, and send those back to our physician teams because we share the same health record, and really be able to partner to make sure the patient has the education they need to stay out of the hospital. That's home health's goal. And we work with the acute care hospitals, Leanne's team, for readmission prevention, and really, so home health can do medication, adherence, education. They can do physical therapy in the home. Our nurses do a lot of wound care. The upstate has our wound population for our home health is one of the highest we know, looking at market data. We have some really great nurses who can come in and change those dressings and help educate the family, safe ways to do that. And that helps keep their family members safe and infection-free. They can just do all kinds of things in the home now. And insurance loves home health because it allows the patient to get care in their most comfortable environment, which is their home.
Yeah. Yep.
And that's where folks want to be. Ultimately, you want to be at home. So to be able to receive that level of care in your home environment, and it really is the best place for the patient to receive that care when needed, because it's a familiarity. I mean, you know where your bathroom is. You know the easiest way. Patients that sometimes struggle with a little bit of confusion in the hospital, once we can get them back in that home setting and bring in the supportive services from home health, things settle back down for not only the patient but their family.
Right. Yeah, that's a great explanation, because there's a lot of evidence about people recovering much better in their home than they would at the hospital. So those of you listening, let's just say, play this out. You have an 80-year-old parent who needs a hip or a knee replacement. The doctor is generally going to want your family member to go home. And it's really not any other reason except that's what generally is best for them. The acute rehab, a skilled facility, might have its place, but if you can get someone in their home where they're comfortable, they know where everything is, have a home care team come in and assess the environment and then provide expert level care, both from a nursing and rehab perspective, the outcomes are quite good. So if you do encounter those things, that's really why the physician is talking about trying to get mom or dad home or you home. It's not for any other reason. So you also, Carly, you hit on something that I do think is worthy of talking about a little bit. You talked about Spartanburg Regional Healthcare being the first at some of these services that are offered. And I think there's really a whole host that our healthcare system has done first. I think the first in the state, or at least the upstate, to do robotic surgery. Certainly the long-term acute care hospital, Spartanburg Hospital for Restorative Care, was innovative at the time. There's a lot of firsts that our organization has done, and there's been a lot of great leadership. So talk about some of the firsts within the post-acute realm that our system is engaged in, and how we've been a leader in the state and the region.
Well, you mentioned some of those. The long-term acute care hospital is one of the oldest, if not the oldest, in the state. And we work nationally with a lot of other LTACs. We've had a lot of research conducted right here in Spartanburg on successful ventilator weaning. We have one of the best ventilator weaning rates in the United States. And really being able to achieve some of those great quality outcomes. We have, if not the first hospice home in the state, I'm pretty sure. We were one of the first, and it's off of Jeff Davis. The hospice home is where folks can go in and get that inpatient level hospice care if they need it. And so really rich in history there. It's a beautiful place if you need that type of service. And so just really coming alongside when folks are having a lot of discomfort, the hospice home is there to alleviate that and really be able to get their medication regimen correct to get them home. We discharge quite a number from the hospice home. That's another myth, not a first, but a myth, that folks always go there and to pass. That's not really true. Our goal is to get them comfortable and get them home. And then we have, it's not the first, but it has been awarded the best of the best. 7 out of 8 years, our skilled unit at Spartanburg Hospital for Restorative Care has won best of the best. Our hospice has won best of the best. Our home health has won best of the best. So we're proud of all those things, certainly for our healthcare system.
Yeah, you should be. I think it points to, for a community the size of Spartanburg, and while it's growing, has really made large investments in healthcare all across the spectrum of the industry. It really have tried to be innovators to provide the community with the care that it needs, and it's really quite a testament to the leadership over the years and the commitment of the folks that do the real heavy lifting to provide services, again, in a community like Spartanburg, whether it's cancer care, some of the technology and operative services we have, to our post-acute care services, that we really are on the leading edge of trying to offer the best of the best opportunities for our community. I think that's a great testament. There's my bias is working here that we have a great organization, but it's really great for people to understand that about Spartanburg Regional Healthcare System. If somebody wanted to, find resources for their aging parents, how might they just go about doing that?
So for post-acute services, if you're looking or want some more information about any of the services we've talked about today, the best thing to do is call 864-560-CARE. That's answered by a nurse on the post-acute team, and she really helps patients and family navigate. I feel like my mother, father, myself could benefit from home health services. What do I do next? Or I feel like we're at a spot where we need to talk to somebody about hospice. That's a great resource. It's pretty easy to remember, 560-CARE. And then we have somebody that answers that, can really help walk them through the next steps to getting them that referral.
And I haven't used, either that phone number myself or just talked to people. I've been in healthcare my whole career, but there's a lot we don't know. If you don't spend a lot of time, when I'm in an acute care hospital, I don't spend a lot of time doing the work y'all do. There's all these rules and expectations and regulations. So you do have expert people who can talk you through that. And believe me, there's a lot to take in. So these people who know a lot, you've got easy access to folks to give them a call. They can talk you through it, because we all are going to go through the living and dying process, and we're going to have parents or family members or other loved ones that are going to need it. And it can be very challenging to navigate. And that's another example of where our healthcare system has gone well beyond just the bricks and mortar and the people care, is a holistic giving people the resources and information they need to make informed decisions. You mentioned a little earlier about the assisted living and nursing homes and what is covered by insurance, but do many of these places take Medicare and Medicaid patients?
So assisted livings won't. But you have assisted living / boarding homes, and a few of those do have some Medicaid, what they consider Medicaid beds, where if you have a Medicaid service, they'll pay for the boarding home or an assisted living. But for the skilled nursing facilities, it's any payer.
Yeah. Okay. And now you also understand, too, again, why the healthcare system grows like it does, because our acute care hospitals would just be full of people who don't need to be there. And there's others who might need that space. There's just better places for them to get care, regardless of their funding source.
Right.
There.
And an acute care hospital is an expert in just that, in the acute care.
That's exactly right.
And assisted livings, they really are set up, and nursing homes are set up as the expert for that level of care. For example, if you have the ability to be in an assisted living, that is the most appropriate place for you, not in a hospital where people are dealing with acute illnesses, but in assisted living where you can really thrive. You're going to the dining room, you're doing those things. Or if you're set to be in a skilled facility, they are the experts to meet your needs there.
Right.
So I think it's hard sometimes when your loved one comes into the hospital, and it seems very quick that, one of my case managers is coming, hey, you were admitted today. Let's talk about what's your plan when you leave. And the reason we do that is because we don't want to catch you off guard the day of discharge. Discharge planning starts on admission for the reason it's not a benefit of the hospital. It's not a benefit of the payer. It is truly the benefit of the patient, so that you're informed, because as we've talked about today, there's multiple steps to get you into a skilled facility or to get you into an LTAC or get you home with hospice. So we want to make sure all those steps are checked and it's a smooth transition. We don't ever want to have to hurry up and make a plan an hour before you're being discharged.
Right. So y'all done a really incredible job sort of in quick order explaining post-acute care services, how it rolls into the acute care hospital and other things that we do. For the listening audience, hopefully they've gotten a little bit of a better perspective on why healthcare systems have evolved like they have, from a traditional acute care hospital to now having employed medical providers, other services. Talk to us about the benefits of why, when you go to the hospital, that organization is going to provide you with many options for the next level of care. But in the event that you stay within our system, we believe there are benefits to that. What are some of the benefits that if somebody was to come to Pelham Medical Center and then ultimately need some post-acute care, home care, a nursing home, what have you, What's the benefit of them, in addition to just being hopefully a great service that we offer and great experience, the benefits of staying in network?
So I'll be glad to answer that one. Initially, I would say the benefit is that we are aligned in mission, vision, and values of Spartanburg Regional Healthcare System. We really want to provide the care to our community in the same way that you sought care at the acute care hospitals. Our post-acute services are aligned. We share the same medical record with primary care offices from Spartanburg Regional Healthcare System, the acute care hospitals, and they can see everything that's going on in the post-acute division. So if you need home health, they can see how many times the nurses come out, what's going on when the nurse comes out, what's going on with the therapist, what's happening in hospice, all the things that are really important. It takes the burden off of the family to remember to take that medication list to the primary care practice. They can see that we have reconciled the medication list from the acute care hospital to the home medications that they've seen in the home. And when you go to your physician's office, it should ease the burden off of our patients and their families. We really try very, very hard in our Spartanburg Regional Post-Acute Division to be an extension of our medical group of the Carolinas, our physician practices, and our acute care hospital. We understand that we are referral based, so anybody can call and request services, and we often get calls many times to that 864-560-CARE number. Sometimes they'll call the home health office directly, and when that occurs, our goal is to link back to that primary care physician and tell them what their patient has reached out for us for. We are just an extension of the healthcare system, so I think that's a huge benefit.
No doubt. I've seen it work firsthand, just with family members who, started at one place and then within our system needed certain other services. That integration has really been incredibly helpful. It avoided unnecessary testing. It helped perhaps explore different testing because of previous results, and it's there for every provider to see. So, doctors aren't having to say, I need records from this other place to try to deliver the best care, and it works really well. And I've seen it firsthand, so y'all do an exceptional job. Well, Carla's nice description there of how all that work sort of gets us back to just how important the case management team is. And so, we've talked about all these different locations people can get care. So maybe, Leanne, just talk a little bit again about how your case managers really help people knock through all the confusion. You've got a sick loved one, there's emotion involved, there's stress involved. The last thing you're thinking about is, okay, I got to do these three things next. But that person can really help navigate people through our system.
Absolutely. You got a lot of great information today, but been doing this for 28 years and have been on the other side of healthcare. I recognize we're in a hospital setting. Some of this you may remember a little bit, but you can't remember it all. But the one thing I want you to remember is that you're not alone in this, and your case manager is going to be super helpful and be the person that you say, I'm going to ask for my case manager. I know there's venues out there. I know there's opportunities for additional care when my loved one leaves here, but I can't remember exactly how it all works. And that's when you say, I want my case manager. And that's the biggest thing. Now there's options for additional resources once you leave the hospital to help take care of yourself. But we want you to know once you get into the healthcare system, somebody's going to come and walk you through the process. And they really do the steps. It is their job to know what payers cover, what the requirements are under the guidelines for Medicare or for the agency that's accepting you. We don't expect you to know all those things because you're expected to be there and just be the loved one. You're the caregiver at home. We're the caregiver when they get here, and we want to help make sure once they leave here, we have you matched with appropriate services. So please, at any point during your stay, we have case managers located in the emergency room, up on each floors. They're here 7 days a week. So please know that they're really going to be a great resource once you get in, because most of the time we're meeting you in crisis or meeting you in an acute phase of your journey. So we recognize these are hard decisions to make. You make the best decision with the information you have, and it is our goal to give you that information.
That's a great description, and it just reinforces there are no unimportant jobs in healthcare, and hopefully for y'all listening, understand that when you do encounter all these different people, there's a reason they have a particular expertise, and they've done this before in a way that they can calmly get you to the information you need and the next step. Do either of y'all have any personal stories you want to share about either great mentors in your life or just funny anecdotes in the daily work y'all have?
Oh my goodness, we're case managers. We would have to change the names to protect the guilty. But it's, I have so many mentors. Like being a part of this system for 28 years, it's a part of who I am. When I retire in a long, long time from now, this system will always be a part of who I am. I tell folks it's not only provided a great opportunity for me, but we've lived through it. Like when I talk about case management and everything the system does, unfortunately, I've had to be on the other side of it. I've come in with my mother in a trauma. I've had my babies here. My father died on our hospice services. So why I'm so passionate about what we do in the acute care setting and post-acute setting is because I've lived it. And when you've had to be on the other side of it, I don't recommend that for anybody, but it kind of made me realize we do what we say we do. We can talk about all these wonderful services, but until you've experienced, I have great confidence that Spartanburg Regional Healthcare Center, Pelham, post-acute services, we do what we say we do. And for me as a social worker, that's the best thing I can give to our patients because we are patient-centered. We want to make sure they have the appropriate resources. So I think I've had mentors throughout my whole career, and they show up just in the most appropriate times.
Good. Carla, what about you?
I also have had the benefit of working with many great leaders and even patients that have had such insight. I will never forget, it was actually a physician who is no longer with us. He said to me, something I always want you to remember. He said, a square peg will fit in a round hole as long as you put enough pressure and you're persistent. He said, persistence overcomes resistance. And so for our families, and patients that we get the opportunity to serve, I have never forgotten that. I've also had family members in each area of our healthcare system and each area of our post-acute system. And I'm most proud that we really do say what we're going to do. We come alongside those folks for their benefit and to help them in their healing journey. As far as if I was going to name one mentor, it would just depend on the time of my career. Now in nursing leadership and really leading clinical teams, you can look back and learn so much. And we just came out of the COVID, pandemic, endemic thing that happened to everyone worldwide. And I think that we're going to have so much learning from that, like how it's shaped us as leaders, how it's shaped our response. It's hard to just point to one person. She and I have shared some similar mentors over 20 years. And it's funny, it's an honor to serve in healthcare and just look back at how we've been able to work together and serve the community. It's really cool. That's one of the things I'm most proud of.
I have every personal card that has been written to me from a family over the last 28 years.
Yeah, those are meaningful, aren't they?
They're so meaningful when you hear back from a family that you really did meet them where they are and were able to help them. I have a little envelope, and it's just so meaningful because that's really why we do this.
That's right.
Yes.
That's right.
Is for our patients and families.
Yeah, it does show you how important healthcare is, and having people who really are committed. And like y'all said, it changes you. You can't be in this business for very long without it really understanding that the mission of the organization is vital, and it is who we are, and we live by that. And it's really about creating an experience for a family. Because we really don't sell anything. We don't sell cars. We don't sell food at a restaurant. We're taking care of people. And I think y'all both summed that up very nicely. I would echo the commitment to mission and that, the right mentor pops up at the right time in terms of learning things. There are things I've learned every step in my journey from, day 5 in my career to now that stick with you. Stick with you. So I can't thank y'all enough for giving us your time and maybe demystifying a little bit about another important part of the healthcare ecosystem and helping people maybe better understand what it means to get involved with a nursing home or a home care service or an acute rehab or even an assisted living, which we're not necessarily in the business of, but there's lots of things that are out there for people to have to endure and explore, and we're here to help them with that. So thank y'all very much for y'all's time and insight.
Thanks for having us.
You're listening to the Pelham Podcast with Tony Kay, the show that highlights all things Pelham Medical Center. Thank you for listening. For more information, visit pelhammedicalcenter.com.